Okay, good morning, ladies and gentlemen. Everyone who wants to take a seat, takes a seat. We'll make a start. So, good morning, and you're all very welcome to the Department of Health this morning for the launch of the National Framework for the Management of Endometriosis. My name is Killian Ryan. I'm the Director of the National Women's and Infants Health Programme. It's very nice to be here with you this morning. Before we get into the substance of the morning, just a few housekeeping issues to take care of. There are no fire drills that we are aware of this morning, so if the fire alarm does go off, please be aware. It does happen, yeah. Happens every Wednesday in Brunel. The doors at the back, there's a door here to my left, and there's another door down there on the left hand side. The bathrooms are back out into reception, which are now to your right and now on the right hand side. We have three speakers this morning. We're going to start with Dr. Keane Murphy, who's the Clinical Director for the National Women and Infants Health Programme. She's also an obstetrician gynecologist. After Keane speaks, Martin Foster, senior HSE will speak, and then the minister will come and actually formally launch the framework. Before I introduce Clina, I would first like to acknowledge the pain and suffering that women with endometriosis have endured in our country. Historically, this has been a very difficult condition, poorly understood, poorly researched, and as a consequence with very fragmented clinical pathways. In particular, because the symptomology is very varied, women have found it incredibly difficult to know what door to enter. And indeed, the minister published some research on Tuesday that said, unfortunately, that's not something that's unique to endometriosis. That happens in other aspects of healthcare for women. The Women and Infants Programme was established back in 2017, and one of the first things we identified was the fact that there had been no structured or sustained investment in women's healthcare. Thankfully, that has changed substantially over the last few years. We have seen significant and sustained investment, and as a consequence, we have a number of programs that have proven both the access and the quality of services people want to do. My colleague Clina will talk to you about some of those in the next few minutes. Some of the money, the investment in the crops came to the Women's Health Task Force, and it was that investment in 2021 that allowed us to establish the first dedicated endometriosis service. Now, we're very much aware of the fact that what we have at the moment is a foundation. We're not able to meet all of the complex and varied needs that women have for endometriosis, but it is a base upon which we can build. We have a dedicated and committed team of clinicians, and with additional sustained investment, we will, in time, be able to meet the needs of those who suffer from endometriosis. I hope what you hear this morning will give you confidence that we are changing, that we're moving in a direction where we will be able to meet the needs, and that the leadership of the Minister and the CEO, the future will be brighter than the past. So with that, thank you, and I'm going to hand over to my colleague, Clina.
Thanks for the opportunity to address you all today. I first met a woman with endometriosis in 1997, which is quite a time ago now, when I was training in general surgery. The patient had been admitted with recurrent bouts of bowel obstruction, and the clinical team were scratching the head, and eventually it transpired, after, I would say, a considerable amount of time, that the events occurred with their periods, and this eventually the penny dropped. Exploratory surgery was undertaken, and this poor one had a narrow segment of bowel which was removed, and she made a very good recovery. I remember it being an interesting case, but I do not recall if there was much post-op discussion or consultation with gynecologists, and it made an impact on me that something like endometriosis could lead to such a major surgery. Time went on, and I moved from general surgery into gynecology, and I was determined that actually, that gynecology wouldn't necessarily be a Cinderella of the surgical specialties. Much has changed since then. There are ultrasounds and MRIs that can help evaluate. Multidisciplinary meetings occur to plan surgery. Surgery itself now is mostly minimal access, and of late robotic. Length of stay has shortened considerably. In those days, if you were in for surgery, you were in for days, 5 days, 7 days. Medication to help reduce recurrences are more available. Knowledge of endometriosis is more widespread, although I agree with you all that this could be much improved. Publication of this framework will make Ireland one of a small number of countries that has such a document. France began this work in 2018 and has recently published an action plan. The UK and Australia also have national action plans. Places like Denmark have very good structures in place, but some countries are not at the level that we are, and this is the starting point for us. As Gillian said, NWIP initially was established to deliver the maternity strategy. Overall, it became apparent that a national focus on gynecology was required. There were long waiting times and variation in geographic access was noted. This led to the establishment of ambulatory gynae clinics across the country. This has transformed the experience of women with abnormal menstrual bleeding and has led to much improved access, with over 20,000 new patients seen last year and a 65% reduction in 6-month waiting times compared to 2020. But not only that, the experience for people is much better, and it's not always about the numbers, it has to be about quality of experience. Menopause care previously was quite fragmented, and those with additional medical conditions were finding it difficult to access HRT. The establishment of complex menopause clinics in conjunction with the governmental commitment to free HRT has been life-altering for women in menopause in a very positive way. Up to 2 years ago, there was no IVF access in Ireland. We were laggards across Europe, and we had limited secondary fertility services. Now we have 6 fertility hubs with the ability to refer for publicly funded IVF. This has only been possible with strong political will, ring-fence financing, and a well-defined programme. And all this has occurred on a background of general demand for gynae services, which has risen exponentially from 20 referrals per 1,000 women in 2017 to 40 per 1,000 women in 2024. And with the knowledge and raising awareness, we have kind of identified this unmet need. Prior to the framework's completion this year, we saw a national guideline on the diagnosis and management of endometriosis. I'm indebted to the national guideline team and the authors and reviewers who included patient representatives. This is a plain language summary and is available on the HSE and RCPI websites. This framework itself has had significant stakeholder input. The listening exercise that led to the Women's Health Action Plan 23-24 was a significant starting point, and events took off from there. And I'd like to thank my predecessor, Peter McKenna, who was involved in the initiation of this. The NWIP team itself has engaged with overseas clinical colleagues such as the Expect Centre in Edinburgh, Endo UK, Australian colleagues, and I'm very grateful to the Endometriosis Association for constructive input over many meetings, again, helping bring the lived experience perspective in, and sometimes having challenging conversations, I have to say, but I think the framework is all the better for it. This framework maps out a pathway from primary care to secondary care, and where required regional and super-regional specialist services. The regional services, Limerick, Coombe, Rotunda, MH and Galway, will have a named lead consultant, a clinical nurse specialist, physio, dietetics, psychology, and dedicated admin. And the admin part is really important when you're setting up services, and we've learned this in recent times. For the super specialised services, Cork and Tala, the lead gynaecologist will also have support from a colorectal surgeon, urologist, radiologist, clinical nurse specialist, physio, dietetics, and again, the admin. Some of these services have already delivered on investment to date, with over 1,100 women treated and 600 surgeries performed. And the intention is to expand some of these services and develop others that are still in infancy. So as I said, we're not done. This is the starting point. The role of the multidisciplinary team in delivering endo services cannot be underestimated. Each individual woman needs in-person assessment, discussion of the impact of the symptoms and the treatment plan that best suits her stage in life. Diagnostic imaging, medication, physio, dietetics all have a really significant role to play. Surgery should be planned, and ideally planned in an elective rather than an emergency way. Fully informed consent regarding the risks, benefits and limitations and complications are signs of a quality service. Pre-op anaesthetic assessment, time to read, consider written information and reflect and absorb is essential. These are really important decisions for people to make. And this has to be a shared conversation with clinicians and women. The role of the clinical nurse specialist is a valuable component of the team, and aftercare and psychological support is really important in such a condition. Ireland has a strong tradition of research and audit, and it is envisaged that these units will report on outcomes which will inform future development of services and also be informative for future cohorts of women so that they can make informed choices. This was will also facilitate attainment of international accreditation. We are fortunate in Ireland to have extremely well-trained doctors who are highly sought after when they go abroad. We have one of the longest training routes in Europe. Most people are trained for 8 to 10 years in obstetrics and gynecology prior to achieving specialist status, and many elect to do further fellowship training for 1 to 2 years. Many of my colleagues who have joined us today have completed fellowships in complex gynecology in places like London, Sydney, France and Melbourne. We embarked on a humorous training with an element of prescience that ultimately endometriosis will get such attention. Our fertility leads also have, in many cases, dual training. I also acknowledge the collaboration that has been fostered between other surgical specialties, urology, general surgery, that has been in the interests of being patient-focused. Developing local medical talent is an important focus for future succession planning, and I would like to acknowledge the RCPI and the NDTP in providing funding for specialist fellowships, and I think some of the fellows are here. Thanks to the Minister, we can ensure that these fellowships are continued, and so that we can produce further consultants working in the area. NWIP will continue to collaborate with the RCPI and nursing, midwifery and allied health groups with respect to supporting continued professional development. We have strong links with international organisations and colleges across all levels of women's health. In closing, I would like to acknowledge the NWIP office team who have worked tirelessly to bring this to a publication. I would also like to thank the maternity and gynae policy unit in the department who have been really helpful in organising the launch today. I would like to thank the Minister for making this a priority for women's services. Finally, I would like to thank all the women present and past who have described how endometriosis has affected them and has motivated the clinical community, management and the department to do things differently. Today is for you. Thank you.
Thank you, Claire, for that very succinct introduction to the framework, and I'd like to call on Bernard Ross to see you.
Thanks, Kenny. Good morning, everybody. I'm very conscious that I'm in a room with a gathering of people, and I'm talking about a very sincere and serious aspect of women's health, something on which we recognise that despite our good progress perhaps in more recent years in this room in early September, the only thing I could do was leave here and say and know and feel that we've come up short for a long time. And I just want to start by acknowledging that. I'm very conscious I'm a grey man, not wearing a grey suit, but I'm here talking to people with lived experience of something that I've never lived, and that I have to start from that place as the leader of the Irish Health Service in terms of the HSE. I have to start from that place of saying, let's pause and reflect. And the Minister contacted me in early September, and I was just coming back from leave, and she said to me, I'm having a really important engagement in a few days' time. And she said, I think it's really important that you come participate in this with me and do it with me. And when I asked her what it was, I said, what do you want me to do? And probably one of the most striking examples of the importance of that event was she said, I want you to forget what you know, I want you to listen. And she said, maybe when we've listened, we can do something to show people we've heard. And maybe when we do something to show people we've heard, we can do that by our actions as distinct from our words. And that's the basis on which we've approached the last 2 months of work. I've been a senior public servant for a very long time. I don't think I've ever seen an action plan or a policy framework come together so quickly with so many component parts. And organisations like ours at times might feel that that somehow is too fast or too much. In this case, it can't be too fast, it can't be too much, and it can't stop you. And so what I want to say to you is that what you see in the framework today, the policy package and initiatives the Minister will talk to, I don't intend to rehearse them all. You'll hear from the Minister in a few moments. But whether it's supporting people now in a very special way with financial support for treatment abroad outside of the traditional treatment abroad schemes, where we've made it easier for women who need services and and we can't yet provide here, that we can now provide that support in a very dedicated scheme that goes live this weekend. And at the same time, as distinct from constantly just relying on going abroad, this very clear plan of building our capacity here, building on top of what Killian and Cliona talked about has been going on for the last 3 years, but at a much more expedited rate, and bringing us to a level of capacity that's responsive, and that's responsive to what we now know is likely to be the case of 1 in 7 to 1 in 10 women who will experience this most debilitating condition. I've read many things about endometriosis. I don't think I'd ever be as impacted in my understanding of something as it was in this room on that day in January. And there are people here, there are women here, and including some who still pursuing their education, who describe some of the most debilitating impact, and who also described that notwithstanding our best effort, if that was our best effort, they also described something which was shocked of responsiveness, that as a healthcare system, we were still that far short in responsiveness. And that's the point to be heard. That's the point for us to step up to the plate and say we listened. That's the point for us to act, and that's the point for us to say with humility that even after today, we've a long way to go. We haven't got this right. We haven't got it all right. This isn't going to work right and smooth for everybody. But our approach and our disposition has to change. And I certainly can say to you, as the CEO of the Health Service Executive from my time, it has changed. It will change. And because of the speed of emphasis in which this package came together, and because of the clarity that the Minister brought to what needed to happen, which meant we all have to rise up above what we know and the limitations of what we know. We all have to, because fundamentally we didn't come up short. I hope today we've come up a little less short, but I hope that that's the beginning of that. And it's really important that this framework is understood, not as a policy context in which we might do a bit next year, we might do a bit the year after. We have to do today, we have to do next year, and we'll probably have to do every year. One of the things that I suppose I found particularly striking is I've often described Irish public services, including health services, as paternalistic. It's part of our culture, it's part of our history, it's part of our education system, it's part of how we treat marginalised communities like travellers and people with disabilities. It's not that we're bad people, but we came from a very much rescue and recovery type of model of social care and intervention in people's lives. And that is very paternalistic and it's very outdated, because what it doesn't do is it doesn't embrace the critical importance of people's right to self-determination, of people's right to contribute and to articulate to what happens then and how it happens to them. And for a health service, there can be nothing more striking than the need to focus on that in the context of women's health. We're sometimes too easy to talk about flags, whether it's women's health or social inclusion or other things. And we've got to go beyond the flag and go into the depth of it and say, what is the lived experience of people? What does that tell us? And using then the best clinical evidence and the best scientific approaches that are in many parts of the world, that we put all of that together. And hopefully we'll come up less short, hopefully we'll come up with a greater response. One of the things today about supporting people to access services abroad when they can't here is it acknowledges the services that are here and the role of those, but it acknowledges that we can't ask people to wait the time they wait. The list of services you'll see is just the beginning. I hope that list will be added to as we learn more and as we see more of different centres and services around the world, and I'm open potentially to how far that goes. It has to be right, it has to be appropriate, it has to be safe, it has to be evidenced, but it has to be available. And so I really hope today that the people who were in this room at the start of September, they felt we listened, that they've maybe begun to see that we've heard, that they start to see some bit of action, and that might just help to rebuild trust for some people that I know is broken. trust in a lived experience. And for many people of a good experience, it's important to acknowledge that too. But we can never default into relaxing and being comfortable and good without hearing where it cannot be shown. Delighted to welcome the Minister for Health to launch the policy framework today, Jennifer Carroll McNeil.
Thank you so much, Bernard, and I'm so glad to be here with you all again on Saturday morning in the Department of Health to formally launch the National Framework for the Management of Endometriosis in Ireland. And I really do want to thank those of you who came this morning and acknowledge that many people were invited for whom it wasn't possible for them to come, didn't suit them, they weren't well enough, they weren't able. The invitation was put out there as broadly as possible, and so glad to see so many people here today. And I want to acknowledge all of those. This is not a finite group. We know that this is a community that goes very far beyond that. I really do want to acknowledge what Bernard has said there in relation to the experience that I hope that we have tried to create and foster since the beginning of September here, and to see some measure of responsiveness to that now this morning, some 6 weeks later, I suppose. And most important in that is acknowledging and thanking the voices of the women who spoke on that day in the patient forum, women living with endometriosis who courageously very openly shared their experience with us here in this room, as well as all of the very many advocates that have spoken so loudly and not necessarily been heard, all of the advocates who went before that day for a very long period, of different ages, in different ways, in different forums, and who were not necessarily heard here, were not necessarily heard in maternity hospitals, were not necessarily heard in so many different settings. And I want to acknowledge their contribution and all of that work that has gone before that. All of that contributes to what we are trying to do and how we are trying to respond now. The patient forum was very, very important, but it did also spectacularly delay the launch of the framework for a very good reason, which is that having spent the time and tried to listen on the day, we did then literally change many parts of the framework in terms of language, in terms of trying to reflect lived experience. And so I think in my heart that the language of the framework has evolved directly as a consequence of what we were privileged to have the opportunity to hear in that patient forum. But I'm very pleased and delighted to be in a position to publish it today. And I really do want to thank all of the people in the last number of weeks as well as all of the patient voices. There has been, as Bernard says, a spectacular amount of work done. We here in the department, in NWIP, Cliona and Killian in the HSE, all of this, the team here, both on the maternity side and the national and women's health more broadly, and the patient forum, patient support groups more broadly, and in particular in my own office, Amelia Francis, who has done a huge amount of work, really at speed, at top speed, to try to present a developed policy framework with multiple different aspects that is responsive to what we know is missing in the system, notwithstanding that many women are getting treatment that they're happy and comfortable with. We are very aware that there are so many as well who are not getting that, and to try to reflect their experience and develop a programme that will start to be more responsive to their need. So I do want to really recognise the body of work that has happened in here, because I know you can't necessarily see it, but trust me, it's been quite different, and it's been really, as Bernard said, at speed, and we really have put our heart and soul in it, recognising that it's not the end of the programme, but it is a really important beginning. I also want to acknowledge the very many people, the clinicians and the College of General Practitioners, who have also really seriously contributed to that body of work, and it's great to see them here today. We know, and we want to state loudly, that endometriosis is one of the most common women's health conditions, one of the most common women's health problems in Ireland today, with no known cure necessarily. And it really has, as Killian and Killiana and Bernard have said, it has been under-recognised for too long, both within the clinical community and within society more broadly, and employers and families. It has been under-recognised for far too long. And now we want to really turn the tide on that, to raise awareness, to expand and enhance our services, to support doctors, surgeons, medical teams in upskilling in the way that they would like to and need to deliver the best for you, their patients here in Ireland. So the framework, for the first time in Ireland, we now have a framework setting out a defined clinical care pathway for women and girls with endometriosis in Ireland. So that is important. And central to the model of care, and I cannot state this loudly enough, central to the model of care is the principle of presumed diagnosis. presumed diagnosis, acknowledging loudly that women are always the most reliable narrators of their own experience, the most reliable narrators of their own symptoms, the most reliable narrators of their own pain. They are not my words, they are the words of the very excellent Amy Brown, one of your strongest advocates. And she said that to me, women are the most reliable narrators of their own experience, and she is so right. And so I asked her if I could use her phrase, and she very kindly said yes. So let me say it loudly. Women are the most reliable narrators of their own experience, and that is the model of care in the National Framework for Endometriosis. I know that every single woman, women with very complex endometriosis has at some point not felt heard and not felt believed, and it is an important frame. So the framework is a very important tool in raising awareness and acknowledging acknowledging that, and trying in the clinical community to reduce, as clinicians want to do, to try to get a solution as quickly as possible, to reduce the time it has taken to get a diagnosis, which we know has been far too long for so many women. Last month I was in this room with senior officials and clinicians to meet, as you know, to meet and to listen, and I'm very, very glad that we had that opportunity, and it really has informed this framework. But the framework is one thing, actions and getting on with things are another thing, and it is important, as Bernard has said, to turn the words into actions. And just so that you're aware, so my role is to set policy and to make sure the funding is there for the policy. It really is now for the HSE at an operational level to get on and deliver that with NWIP. And that is an important body of work now. But the policy direction, let me be very clear, is a couple of different things. I wrote to many of you at the patient forum about the number of steps being taken over the next period. So let me just set out and reiterate some of those. We have an additional 100 surgeries to be carried out this quarter, i.e. between now and the end of Christmas, at the end of the year, across the different regions, focusing on the more complex or the longer waiting for patients. And that is an important and significant addition to the number of surgeries that would otherwise have occurred. And that additional surgical work has begun on the 1st of October, and I will get my first update in about 2 weeks with details about which region, which surgeon, and crucially the types of surgeries as well, so that I can begin to understand and track that over time as well. And I highlight the type of surgery because so many of you have come to me sharing your frustrations with different types of surgeries and with the effectiveness or not of different types of surgeries. And I have to be clear that it isn't my place as Minister for Health to enter into debate, a clinical debate as such, about the nature of surgery or excision versus ablation as such. But I am a public representative and I am your voice in many ways. And so it is very important that I articulate your voice to say that there is a dissatisfaction and a conversation to be had, I suppose is the best way of saying, about the nature of different surgeries. I have heard what you are saying to me, but I'm not a clinician, and it would be dangerous for me to step over that line. An additional colorectal surgeon has already been advertised for recruitment to support more complex surgical treatments, and I am being kept up to date on how that recruitment process is going. The HSE has carried out a thorough analysis of the short-term and longer-term requirements to build what I believe to be adequate capacity to improve clinical pathways in the way that I would like to see, and to increase expertise within our services in the way I think is necessary. As you're aware, the department, we've just gone through a budgetary process. The overall health budget now, we have had an uplift of 6%, 6.2%, which is really important. And the way that that works now is I work out with the HSE how we determine that amount of money throughout the different regions. We're trying to achieve regional equity so that your experience in Donegal is equivalent to the experience in Dublin, and we really are not there yet. And that is a complicated process for us to go through. But in general terms, let me say this: while we have invested in endometriosis to date, we have recruited about 50 people into this service in phase 1, shall we say. I do expect the need to recruit between 60 and 70 more people into this space over the next potentially 18 months. And there is despite that would be allocated around different regions, but that is a very significant investment into a clinical area, into an area of diagnosis. So while we deal in broad numbers on budget day in terms of an overall 3,300 people into the health service additional, I'm just trying to give you some more detailed specifics in relation to how we see that in endometriosis. So that's additional staff, some who will be working in expanding endometriosis services. Bernard has spoken to this, and in particular, let me just acknowledge Bernard's work and the HSE's work, and it is their work to support women who need treatment abroad and who need surgical treatment abroad and who have needed surgical treatment abroad. This is a really important piece of work, and we'd like to try to explain that a little bit further. It really is through the HSE, but it is to try to recognise that there is a cost to it and a process to it, and the work that we're trying to do is to make that simpler, easier, and I'll perhaps leave Bernard to explain the details of that, because it is properly for the HSE and not for me to step across. There's also been an endometriosis priority actions advisory group again, which I asked to be established. It has now been established thanks to the Women's Health Task Force for their work. That group will have their first meeting before the end of the month. There are four women with endometriosis on the group, as well as members of the Department of Health, the Maternity and Gynecology Unit, Women's Health Unit, the Mental Health Unit, NWIC, the Irish College of General Practitioners, and the National Women's Council. And I want to pay special thanks at this point to Tara Logan Buckley, who supported all of us at the forum last month. She has also been, I'm delighted to say, she's agreed to be part of that advisory group, and I think she brings something very special, as she did on that day. And it's an advisory group who I think will essentially provide expert advice, oversight, personal input and reflections and guidance around the priority actions. Tara is very sorry not to be here today. She asked me to say that. But she did specifically ask me to put a call out to some of the younger women here and to some of the community, to younger women in the communities to partake in an awareness campaign that Tara is working on as part of her job with Spun Out about endometriosis and the impact on mental health. Spun Out, of course, is a sort of a younger person's organisation, and Tara is working with them, and she asked me to put that out, and we'll get more details from Tara on that. But perhaps you might link in with me if there's an interest in that, but it really is Tara's body of work. Finally, for now, we are inviting international endometriosis experts to collaborate, to engage with our clinicians, to improve endometriosis treatment options, to build expertise, to share learnings. I was told about one surgeon who, from a hospital in Ireland, who was planning to travel with one of her patients to not supervise, but to observe a surgery that that patient was getting elsewhere. And I just thought, wow, that's absolutely fantastic. Like, we have a phenomenal clinical community in Ireland. Endometriosis hasn't been well enough understood. But what I've seen from clinicians is, yeah, let's do more, let's do better, let's be fantastic. And what Cliona said, I think is really important. Ireland is one of the few states in Europe, while there's good treatment elsewhere in Europe, we have a framework and we have a desire and a drive to be able to give the best surgical solutions to the women of Ireland. That is where we want to get to. And we all in this room recognise, including the clinical community, who have been trying to support so many women, and I know who want to do more to support women, and I'm really, really encouraged and thankful to them for their role in that way. But how are we going to do some of that? Our endometriosis clinical specialists now are going to participate with international accreditation, I can't say that word, accreditation recognition through the British Society for Gynecology and Endoscopy. A range of engagements and opportunities, including a focus on endometriosis at the Royal College of Physicians of Ireland annual conference in March, are being pursued. In conjunction with the publication of this framework, Bernard and I have written to every GP across the country, informing them of the framework launch, informing them of the framework, trying to drive awareness of such a common condition for those GPs who are not perhaps as aware as we might hope, many are. A similar letter will be issued to the clinical community in the coming days. The HSE has also planned a GP practice update and an endometriosis awareness campaign to follow on from the publication of the framework, maintain the focus and the work of raising awareness. Through this national framework for endometriosis, together with the commitment of our clinicians, our advocates, our policymakers, and most importantly, the women affected by this chronic condition, I really do believe that we can, as Bernard has said, take steps towards transforming the model of care that has been there for women, particularly with complex and severe endometriosis. I do recognise I have met so many women who are being cared for in a way that is working for them, and I want to acknowledge and recognise that absolutely. But I really also acknowledge that there are many women who have not gotten the level of treatment that they have needed, that they have suffered as a consequence. We do not want that to be the standard in Ireland. We need to together lift our standards, lift our expectations, and you will never hear from myself or Bernard Gloucester that we feel that we are there yet. We come to this with complete humility, with complete dedication to try to improve the services, to want to try to make sure that people's experiences are lifted and better overall, and that we do not have young women suffering in pain when they're supposed to be going to school, when they're supposed to be playing sports, when they're supposed to be living their lives. That is not the situation that I want for women in Ireland, for girls in Ireland. And I really do believe that with this level of commitment, it will take us some time, but we will improve this and we will make this better for the girls and women yet to come. I'm so glad that we have managed to get this piece of work done quickly, and really I see this as the launch and start of a different model of care and a different, I hope, attitude to women, a different attitude to listening to women, and I hope a humility that comes with this different way of looking at endometriosis, presumed diagnosis, with the woman's voice at the centre, recognising always that women are the most reliable narrators of their own experience, their own symptoms and their own pain. Thank you so much.